So week 9, we got a few things due. It's just a discussion question, and you have calculation worksheet. Now that calculation worksheet, you can print it off of your modules. I don't care if you write on it, you upload it page per page, upload it completely. If you do it typed, it doesn't matter how you get it to me. Just get me all the pages. And I'm going to tell you, I need to see your work. Now, calculate with confidence. All your answers are in the book. You just have to need to go to look at them. There's different ways of looking at calculations. And then you're going to say, but some of these calculations are off the wall. Well, yes, they are just showing you different ways to figure out stuff. Now, I will tell you on your HESI for PEDS, they're very simple dosage calc. It's more your dose, your have, and your quantity type questions. It's nothing mites per kilo and maybe an mLs per hour. There's nothing more than that. I mean, you're going to get those big type of dosage questions on your med-surg HESI. Even your community would have more than, what we do on the pediatric one, okay? So doing that dosage calc worksheet is going to help you understand it and give you some more practice. Again, anybody who needs help with it, let me know. I can help you very, very quickly with it.
So we can write it
Right.
on a regular piece of paper and
Write it on a
just
piece of paper,
screenshot it.
upload it,
Okay.
screenshot it, page by page, all the pages, whatever works for you. Doesn't matter. Whatever you can do. I know I would do it a different way than somebody else. Some people can take all like screenshots and put it in one and send it with a zip form, whatever works, whatever you know how to do. I don't want to stress anybody out, whichever way you get to me. It does have unlimited uploads, okay? And then you have, one of your discussion questions again with some more information, that's important for you to understand. Remember, go back and look at them. I put some interesting information in the comments after they're graded, okay? So week 9 is muscular, skeletal, and neuromuscular disorders. So let's first start with muscular, skeletal, articular. That means joint problems. So it could be a broken arm and you're now with crutches. It could be that top right one. That's a Pavlik harness. Do you know what a Pavlik harness is used for? That's for hip dysplasia in the infant. And we're going to go on that a little more. And actually, that picture right there, I would like you to tear it apart and tell me what's wrong with it. They need to have a cotton t-shirt underneath because that legs are pulling and there's going to be a lot of irritation on that poor little infant, okay? It's a Pavlik harness. And then below is a Buck's traction, and then there's a spica cast in the bottom right. So different things that we do with muscular skeletal. So let's talk about the child who's immobilized. You have a child who's immobilized, and you think that only adults are in hospitals long periods of time. Well, you're wrong. Um, Children have a lot of things that they're born with, congenital, that are progressive, that can, have more problems keeping them bedridden. They can't breathe right, or they need to have something to breathe for them. It could be due to many, many, many different reasons. It could just be that, what about therapies that prolong mobilization? I'm going to give you the biggest one from last week. What about dialysis? They've got to be in there 4 to 6 hours, 3, 4 days a week. I mean, that could be, a child that's not up and moving, and they need to have that motion, for the good body and muscles and our lungs, etc. What happens when you're immobilized? Your muscles get weak. They get atrophied. You're not going to be as flexible. Your bones are not going to be forming as correctly. The problem a lot that we think about when you're immobilized and you're bedridden, it's your lungs and it's, your circulation. It's, having edema, where, you're just sitting there and this dependent edema and it's in the legs. It's down into the hips and this venous stasis is going to be causing things like DVT and problems, pleural effusions, et cetera, et cetera. So again, we're trying to prevent all of these things. Now, a kid has to be on bed rest and has to be in the hospital long periods of time. These children sometimes, especially if they're like, for instance, let's say the bone marrow unit, right? They're in a room by themselves and it's sort of sectioned away from everybody. I know that's the hospital I worked at, and most bone marrow units do have these quote isolation rooms that you have to get dressed up to go in and come out. So not a lot of movement going in and out of these rooms. So you are in there. Think about this child. There's not much around. You're frustrated, you're helpless. You just want to be better. You want to be out, in the world with your family, with your friends. You become depressed and angry. You become very aggressive because you're so angry, you don't even know what to do with yourself, right? So again, effects can cause them to, regression, cause them to urinate, be incontinent when they're younger kids, or suck their finger, or whine, or act in more childlike behaviors. Absolutely normal. If you had to be stuck in a room, immobilized, can't move by yourself for long periods of time, you feel the same way. Now think about the family on the other end. They're feeling the same. So again, um, having support for the family and this child during these extended periods of immobilization are very, very important. The hospital that I worked with, I was very blessed. This hospital had every single unit had a family group. It could be either with the cancer group or the asthma group or the cardiac group, the newborn group. This is families that get together. And in our facility, it was once a month, and it was quite active, these family groups. And they'd get together and they basically talk about how they were coping with their children in the hospital here and there. Also, offering tips and suggestions, and maybe, get ideas from other families on things that are offered that they didn't know about that could help their child. Now, traumatic injuries, we're going to talk about sprains and strains and bruises, ecchymotic areas, et cetera, et cetera. We know kids, they're going to fall. They're just walking and talking and falling down. And it's just kids, it's the way that they learn and they grow, right? They have fun outside doing these things. Now, ecchymotic area contusions. Remember, just because you have a little bruise on the outside, sometimes you don't know if that bruise goes down deep. You don't know if it's occluding blood vessels. So every time you see a contusion, especially bigger ones, always check distally your neurovascular signs. There's always going to be nursing care. Contusions, sprains, strains, breaks, fractures, anything. Always check neurovascular signs distally. That's what we're looking for. A bruise, an ecchymotic area, a contusion, especially if it's a crush injury, could stop blood flow. That's a big thing that we really should be concerned about. Now, dislocation is when a bone pops out of a socket. The biggest one that I've seen in children is the nursemaid elbow. The elbow when you're swinging around like this, and they're, oh, that's fun. Come on, Nana, do that again. Sometimes their elbows pop out of socket. Their tendons are so, they stretch so easily, they pop, and the arm's just going to hang to the side, and it's dislocated. Now, all we need to do is a quick adjustment and put it back in and rest the arm. That's the biggest dislocation. Now, think about our Downs children again. Downs children, there's so many things that we've talked about this quarter regarding them. This is another thing. These children are extremely flexible. They could put their legs behind their head, right? What happens to their hip joints? It could pop. The problem with having these children do that, and we know that they can, and they do it because they think it's funny, they don't know better, right? Remember, they're cognitively delayed. If it pops out, the head of the femur, the blood vessels, blood supply can stop, and the head of the femur can die. And then you're into hip problems, hip replacements, et cetera, et cetera. So we wouldn't want to encourage it. Now, sprains. Sprain is when you twist your ankle. Sounds like an easy thing, right? Well, I've been very active in sports and I've sprained my ankles more times than I want to tell you about. I think the one that reminds me the most was going up in volleyball, spiking a ball, coming down on my ankle, and it ripped. And let me tell you, I was pretty high for a big girl like myself, and I could hear it rip, and I still can hear it. And immediately the swelling occurred, the bruising started, the pain, et cetera, et cetera. So, sprains, what is the treatment? It's what we call the rice, right? Immediately rest it, ice it, contain it, elevate it. That's always going to be your treatment. Sprains, strains, fractures, anything. Elevate it, ice it, contain it, get it there so that we can get it to where it needs for treatment. Today, we do actually cast and splint sprains. When I first started in nursing, we didn't. We just had sprains, just needed an ace bandage and it would heal by themselves. Today, we know that putting on a brace sometimes is a better choice. Now, strains is what we do with one muscle group. We do it over again and over again. It could be like a person who rides a bike and they do it competitively and all they do is ride a bike. Well, all their leg muscles could start to hurt, right? Or maybe a runner, it could be their shins or et cetera, et cetera. But strains, they're little micro tears and it becomes very painful over time. As I said, the treatment, any soft tissue injury, strains, sprains, etc., is it immediately arrested. I got to know if I sprained an ankle, I sat down immediately, put my leg right up in the air. I knew the coach was coming with an ice bag, and then we would put an ace bandage on it and we keep it elevated. You know, the immobilization supports, those are also things, that could be done to keep it from moving and it helps with the pain and the healing. Now, fractures in children. When you fall down, what do you do distinctively? Just instinctively. You put your hands out, right? Because you don't want to fall on your face. Well, what's the biggest bones broken children? The wrists. Because they fall down, you put your hands out. And that's why it's the most common. I've actually seen bilateral fractured wrists, those hoverboards that are so great out there. The first year they came out, believe it or not, I still remember. I had two boys, like 10, 12 years old, that came in right after Christmas, both bilateral fractured wrists, being on a hoverboard, didn't have any wrist braces on. So it is something that can happen. Now, what if you see an infant who has a fracture? It's very hard to fracture an infant anywhere, whether it be a scalp, whether it be an arm, a leg. It's extremely difficult. So if you see any fractures in an infant, remember, you are the advocate for your child if you're a pediatric nurse, okay? That's who you are there looking after, making sure that child's going to be sent home to a safe environment. So any fracture in an infant needs to be investigated to make sure that that child's not being abused. Now, types of fracture. Simple, normal fracture, breakdown, fall down, you break your bone, let's say the wrist swells, and it hurts, but there's no bone sticking out. That's a simple fracture. Most of the time, they're just cracked, and all you need to do is put a cast on them. You don't even have to manipulate them to get them back in alignment. Now, there's also something called an open or a compound fracture. This is most complicated because now the bone's coming out the skin. Once the bone comes out, the skin's infected, right? And we're worried about osteomyelitis. Osteomyelitis can cause a really systemic bad infection and could cause loss of limb. So again, IV antibiotics are priority in any open fracture. Now, yes, it hurts, but you're treating a symptom. Again, remember, am I going to treat the cause or prevent a problem, or am I going to treat a symptom? I want to make sure I take care of the cause. Of course, I'm going to take care of your pain too. My priority is going to be IV antibiotics. Now, there's complicated ones. I think the one that I explain this the best as is rib fractures. If you have rib fractures, they could go in to puncture your lungs and cause pneumothorax. It's a complicated one, all right? Comminuted, little pieces all over the place, and they hurt because little sharp edges everywhere. And then there's something called an avulsion. The bone pulls away from the tendon or ligament. And that's a type of fracture, but it's the bone comes away from the tendons and ligaments, and they have to get them to reattach. Now, there's some sort of break in children that is extremely important that we take care of the best way we can. Now, children are always growing. They grow in their bones, and they grow in a place called an epiphyseal plate or a growth plate. If you look at it, it's the bottom of the bone that attaches to the next bone, okay? And these things grow, and it gets you to get taller, a longer arm, a longer leg. Now, if they're fractured and they're not aligned perfectly, you're going to have a crooked or a shorter arm or leg. So, how do we treat this? All of them are going to get surgery. They need an open reduction internal fixation. They need to put that piece of bone, put it together, put a plate, put screws, make sure it's absolutely where it needs to be so that bone grows the way it should and it's not crooked. Okay. Now, children, I think this is one of the most interesting things. And it makes me understand a lot more about children and their bones and casting. So, neonates, this is your infant's ages birth through 28 days old. Look how quick they can heal a bone, 2 to 3 weeks. Why is that important to know? Well, birth, why would an infant need bone healing? Well, one of the things is fractured clavicle, right? So you put on a clavicular splint, 2 to 3 weeks, they're healed. Pretty cool. But what about club feet? We're going to talk about that in a little bit, okay? Club feet is it could be any way that your feet go. I mean, crooked in, out, like some pretty bad. Got some great pictures to show you. But we put casting on them every week and we straighten out their feet and their ankles. Pretty cool. Also, kids fracturing their arms. It's 4, maybe 6 weeks that we see these children with casts on. They heal so quickly. So, I mean, usually it is that week, the first week of summer vacation. You can't imagine how many kids come in with broken arms and legs into the emergency room. And I'm thinking, well, at least it's only 4 weeks they'll be in a cast because then they'll be able, to act like kids on summer vacation. Now, if it was me in June getting a cast on, maybe by Christmas I could get it off because as we get older, it takes longer time. And that's the point of this. So you get the kid coming in. They're telling you see a swell and let's say it's a wrist, that normal forearm fracture. First of all, we're going to check neurovascular signs, making sure there's blood supply. Then we are, of course, that history, mom and child. We want separate histories. The problem with fractures is sometimes they're normal. I mean, people all fall down and break their bones, but there are times where it is from abuse. So, as a nurse, you've got to figure out, was it abuse or was it a normal kid, right? So a lot of times I would take these children to x-ray and I'd have the parents stay outside because, radiation. I'd bring the kid in and I'll say, so, oh, why was that monkey bar that you fell off of? Seeing if they have the same stories. Making them, I don't want them threatened, but I'm going to start being silly and asking these silly questions. And oh, you're up there all high. And did you do this? And did you hold on with one arm? And, being, and let me tell you, children will open up. Another thing about fractures, you have a kid walking in and they're limping or don't want to put weight on a leg, it's absolutely going to be, it's going to be fractured. If they set it down, a limp on it, it's going to be more of a sprain. Always, when they can't, it's going to be a fracture. So what is the goal? You have a kid coming in with a fracture. Well, you want to make sure that you prevent deformity, right? You keep the function the way it should be. So you reduce it, immobilize it, and let it heal. So after we get the cast on, after we are about evaluating to send them home, teaching parents, teaching children, and also monitoring this ourselves are the 6 Ps. And you need to know these 6 Ps. You need to understand, is there pain there? What is it like? Um, what does the fingers look like or the toes, or depending on where the cast is? Are they pale? Are they pink? If you can feel a pulse, can you feel a pulse there or not? Okay. Is there numbness there? Is there I can't move my fingers anymore, or is it a lot of pressure? Remember compartmental syndrome. This arm on the bottom right is the extreme of all extremes. But if you have a cast on, you don't check neurovascular signs, that could happen because it could occlude all the blood vessels. So that was my point with this horrible picture. And I apologize because it is a horrible picture. Now, casting for fractures. If you work in a pediatric hospital like I did, I was blessed because we have orthopedic techs that are pediatric orthopedic techs, and they could put casts on right within the emergency room. And the best part is they had all different colors of casts. Now, where I live in South Florida, all the adult hospitals have white casts. But guess what? We have pink and green and red and two types of pink. We have two types of blue. We have army, we have rainbow, and we have yellow and orange and red and green and da 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 da. Da. You can see now, not all the colors all the time, but we had a really, really good variety. Why do I mention that? Well, kid's afraid, and all of a sudden, there's somebody person is putting something on something that hurts. Now, if you make it a pretty color, it's not going to be as threatening anymore. So again, putting on those casts, doing the colors is a great distraction thing. Now, when they go home, they need to know how to take care of their cast. There's all sorts of plastic bags, short arm, long arm, small, medium, large. It's giving them what they do need. And again, making sure when they go home, cool air dryer underneath is good. Nothing sticking underneath those casts. No powders, no lotions, are very, very important. I've had children, believe it or not, go home after a cast being put on, put the bathing suit on, and go jump in the pool. The mother turns around, brings them in, and says, "You're not going to believe this. He just went home and jumped into the pool." Well, I saw that kid do it 2 times. And on the third time, he wasn't coming back because the mother was about to shoot him because you have to go through the whole ER process when you're coming in and out to get cast it on and off. So again, keeping them not wet, keeping them dry, keeping their skin intact, nothing underneath and sticking in there. Now, sometimes we have to use traction for fractures. Upper arm extremities are very, 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 very rare. Any sort of traction in children. Usually it's the lower leg. And the most common of all is a buck's traction, which is what that's depicting on down there. So what it does, it pulls the leg. So if I had a fractured femur and I pulled the leg, I would make those bones more aligned. And when I made them more aligned, the muscles around stop spasming. There's no sharp point sticking into muscles or nerves, and that child's going to be more comfortable. Until we can go and do surgery, and they put a rod through the middle of that femur to keep it straight again. Years ago, we didn't do that. But now that is the treatment of choice. So they don't have to go through a month of being in a hospital bed and Steinman pins, and traction, and blah, blah, blah. But traction preoperatively saves a lot of discomfort on these children because it relieves the fatigue in those muscles. It puts those heads of those both sides of the bones together so they can heal better, right? Prevents that deformity, and the big thing is that reducing the muscle spasms. There's different sort of tractions. I mentioned them. The one on the bottom left is a halo traction. I use that in a little boy, and I'm going to mention that when I get to it, a C5, C6 fracture. I had to admit him to the ICU, the PD ICU, and he had to have surgery the next day, but it was a late Sunday evening, so they were waiting until Monday to get it done. And we put tongs in his head to hold that spinal column straight because he already had deficits in his legs. He had one leg was numb and the other one was feeling numb. The other one on the right is more of a distracting device. It's a halo, it's called. We use that for a lot of upper cervical spine things. There are different types of surgeries where we have to go in. Chiari is one of those things where this C1, C2, there's issues in the cerebral spinal fluid, and they put this thing on to let that spinal column heal until we can take it off. Again, all sorts of traction are used. What is your job in traction? So box traction, as I said, used for femur. If we look at the picture below that up the upper right, that's Russell's traction. It's just like Buck's, it's just an extra piece in there. What do you need to know about Buck's traction? What is your responsibility? Keep the legs straight, keep that weight hanging freely, checking neurovascular signs distally, the toes. Is a pulse still there, right? Those are things keeping the heel off the end of the bed so there's good pull so that we keep that femur bone together and keep that muscles from spasming and all that pain. The other type of traction in there I want to mention is the bottom right, and that's Bryant traction. This is used for children less than 30 pounds with hip dysplasia. That Pavlik harness that I mentioned in the first slide, it doesn't work. And this we put the hips on a right angle, okay? And it holds them up, and then the weight goes up and over and hangs. And it holds the buttocks off a little bit, and it tries to hold those hips right to where it will go back into that socket. So again, it's used for hip dysplasia. The hips are slightly off. It's a right angle for children less than 30 pounds. Now, there's another thing called external fixation device. And you're looking at this thing and it looks like a Frankenstein, doesn't it? Why would we use this? The one time I see it used a lot is really bad fractures with splinter pieces everywhere. That's one of them. Another one is when a leg, one of them is shorter than the other. And they could break the bone, put this device on, open it up, the difference, let's say it's an inch, and then it will heal. And now you made one leg the same size as the other. With these pins, it holds it in place. What do you think your job is with all these pins and whatnot? Pin care. Neurovascular checks. And actually, I had, believe it or not, my primary care physician in his 50s had this done on both legs. And he said the thing doesn't really hurt. He says it's just very clunky and it's very difficult to manage on an everyday thing. And I'm like, why at 50 would he do this? But he wanted to be taller for some reason. Whatever. But again, he had these external devices on. I hadn't seen one in a while. And they're the Frankenstein machine, but they work and they work really well. Especially if you can imagine if one leg was 2 inches different and now they can walk evenly, it'll decrease back pain, neck pain, and everything. So they're good things. Another thing is children with amputations. You're going to go, what? Children and amputations. Well, sometimes you're not born with a limb, an arm, a leg. I've seen those things. I also had a friend whose daughter was born without a fibula. She had an ulna in her lower leg, but not a fibula. So she had to have an amputation because there was no way to replace just the one bone. They had to just take the leg off, at least at the time where that was done. Again, treating amputations, just like adults, what are you going to do? Number one, you're going to treat that pain, that phantom pain. You're going to check that stump, making sure that there's no irritation, no breakdown, right? Let me tell you, that little girl that I met, I think she was 4 or 5 when I met her. She took off her lower leg and was chasing my kids all around a 2-story house, laughing and giggling and having the best time ever. And she didn't care if she had a leg or not. And my kids didn't care. They just said, please, could you take her leg away from her? She's hitting me with it. And it just became, okay, could you keep your leg to yourself? And it became one of those jokes between us and whatever. Children are so resilient. That's why I love working with them. Now, children in sports, remember, there is so many demands physically, mentally, and again, making sure they have the proper equipment when they're in sports and preventing those overload injuries. Overuse injuries, I've mentioned them. It's like that strain. This is, like preparing for Olympics, preparing, to have a college scholarship with gymnasts or whatever it is. They push themselves so far that again, you get these overuse syndromes. Now, here's your developmental dysplasia of the hip, DDH. This is the hip is born up here. It's not born where it should be. And this is at birth. We see these things, okay? Congenital dislocation of the hip. Girls are more than boys. Now, how would you know that a baby's hip was not in the socket, but somewhere in here? Could be from here up to here, the most severe. Well, number one, if this hip was up on the right side, that leg is going to be shorter than the other one because that femur is pulled up, okay? Number two, sit them on their tummies, you're going to see their gluteal folds. One is going to be higher than the other. You're going to be hearing that click, click, click going on when you when you look at these children. The pediatrician, the first visit on any infant, takes the knees, put them to the chest, bring them down, open the knees back and forth. He's looking to see if that child's hips are in place. So again, it's a positive Artelani, positive Barlow, short leg on the affected side, and unequal gluteal fold. So how do we treat it? Well, remember children and remember bones and remember how quickly they heal, right? As soon as you possibly can, get them in that Pavlik harness. Now, do you see this picture? They have a little t-shirt underneath protecting the skin from that harness that's going to be moving. So that harness is on 23 hours a day. Take it off to bathe them, inspect the areas, rub the areas with lotion, put another t-shirt on, Pavlik harness on to abduct those hips so that they can go back into where they need to go. If this Pavlik harness doesn't work, they might have to put on a spica cast as they get older, like after 6 months. And then sometimes these kids didn't get to the doctor quick enough, and now these tendons are all tense and tight, and you can't move them. They might need surgery to clip them, to open them, to stretch them. Again, bones, infants, born, club feet. No, you don't have to know all the names of all the different types. Just know club feet can be in, out, up, down, round. It could be all over the place the way those ankles look. That's all you need to know is that the ankles and the feet aren't in the position they should be. How do we treat it? Well, we're going to have to correct that somehow. And what we do is something called a Ponseti method. And all it is every 1 week, we change the cast and reposition the ankle and the foot to get it back to where it should be normally. Every week. Because remember, it's 3 weeks, everything's healed. So we got to do as much as we can every week here, okay? When this child grows, because they've had issues with their feet and the ankle, they do need follow-up by orthopedics or podiatrist or somebody to make sure that those feet and those ankles are the way that they should. But this child, put them in the cast, change them every week, and they usually do very, very, very well. Now, congenital, degenerative disease called osteogenesis imperfecta, or OI. One of the saddest disease, there's no cure, and it's brittle bone. It's you can literally touch and squeeze a little bit, like to pick up a child, and you could crack a rib, crack a bone. I mean, this is how brittle the bones are. I've seen actually only one very bad one in my lifetime where we had to take a baby blanket, put him underneath this little boy, and a nurse would take one side, I'd take another to lift him on the blanket. We wouldn't even use our hands because we were so afraid that we would crack this child. There's no treatment really. It's only like supportive, maybe 5-phosphorus therapy, maybe this, maybe that. But the goal is if these bones are breaking, that we keep them in a position that this child can still remain mobile, like to get into a wheelchair. I tell the stories. It's so if you've ever worked at children's hospital, complete children's hospital, where you work the day shift and you're going to the cafeteria, and all of a sudden one of these kids in a motorized wheelchair, and he's OI because of the disfigurement in the hands or whatever, and they're just buzzing down, beating you, going beep 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 beep, like move out of the way. Their minds are so clear, they're so normal, but their bodies just can't. The other side of OI is sometimes parents are accused of abuse because the OI hasn't been diagnosed. Can you imagine that? I just can't. Another condition, leg calf birth. This is another bone thing. It's what we call aseptic necrosis of the femoral head. Well, what is that? Well, aseptic means no infection. Necrosis means something's dying in the femoral head. So apparently there's some sort of blood flow, ischemic aseptic necrosis. It's not going to the femoral head. The femoral head is dying, and it could take the whole femoral head needing a replacement at some point. Okay. It's usually in males, usually one side, although it can be both. And it usually starts with a complaint of my hip hurts, or you see your kid limping, or they're rubbing their hips, especially when they sit for a while, or in the morning when they wake up. It's almost like a juvenile idiopathic arthritis type morning wake up, but a little bit different. Okay. So what we do is we take an X-ray, and we'll see this little fuzzy area on the top of the femur, and that is showing us there's some infection there. So how do we treat this? Well, usually these children are sent home. They're on bed rest. Sometimes we put home bucks traction on them just to hold the hip straight, so it's no movement, so that it can heal correctly, right? No weight bearing at all on this one. NSAIDs, as non-steroidal anti-inflammatory drugs, work really good. And usually with that, it will take care. And of course, we got to remember always good nutrition, good protein, good nutrition on any child with any sort of bone infection stuff going on here. Now, three spinal things, column conditions. One is called kyphosis. This is what we call humpback. It's the upper type of spine it humps in. Lordosis is your lumbar spine, where it flexes in, and sometimes you walk like with your abdomen out in the front and your body back because of the way it flexes. Now, scoliosis is the S-shaped curvature of the spine. This is usually, we might see it in early childhood, but it's usually about that pre-adolescent growth spurt time where they grow that big growth spurt, like 20-25% of their height. And all of a sudden, we start to see this curve. Usually, you bend over, you see the arm laying down, or one arm shorter than the other. You start to see different things going on. So once they're diagnosed, they're given what we call a degree of curvature. So most spines, most scoliosis is not a spinal curvature that's greater than 40 or 45%. Now, usually it's under. So the muscles are going to need to be strengthened, and you need to put on a harness. This brace here is 23 hours a day again, with a cotton t-shirt underneath to prevent the rubbing. Again, no creams or lotions underneath there. And there's the exercise that they do with it, and it does help. This is for 45, 40, less than type of degrees. Now, if it's over 45 degrees, this child, with all the amount of physical therapy, it's not going to really significantly enough straighten that spinal column out. Because think that spinal column is pushing over into the lungs. So it's a lot about respirations and that lung being collapsed. That's why they want to straighten it out there. Now, above 45, they're going to do surgery. And in surgery, they do something called Harrington or Luque rods. Sometimes they do like this thing called spinal column fusion on on the spinal column, but these rods, it's two rods on either side of the spinal column, and they attach it all the way down. Now, postoperatively, this is your log roll patient because you have to keep that spine straight. Can you see that? You know, with that turning on that child. April, could you turn on your camera, please, for me? April, Miss April, turn on your camera. I appreciate it. Thank you. Osteomyelitis. This is what we were concerned about with infections that get into the bone. Signs and symptoms: redness, swelling, pain. Do a CBC, you're going to see a lot of white blood cells or leukocytosis, right? And it's that fevers and the chills. How do we take care of this? Well, number one, you do your x-rays and bone scans and take care of it, but it's going to be IV antibiotics at home. Now, usually when it's an osteomyelitis, it is usually a staph infection. So what sort of antibiotics are you going to use for a staph infection? Aminoglycosides. Those are your SINs: vancomycin, gentamicin, amikacin. It's the SINs that we are worried about renal and hearing on these children. They need to be followed up. We do PEEPs, we do troughs, remember, because we want to protect the kidneys and protect the ototoxicity and the hearing loss on these children. Also, osteomyelitis, we want to put these children on bed rest, relax the area, take care of whatever pain, and then again, nutrition, nutrition. Again, any infection, you need to feed them, you need to give them good nutrition. Ewing sarcoma is a bone sarcoma, and it could be a scapula, it could be a jaw, it could be anywhere. Some can be removed, some can't. And again, it's radiation, it's chemo, and it's a surgical resection if you can take out that piece. Now, JIA, I've mentioned it shortly, but JIA is the body saying joints, I don't like you. And it goes in and irritates and it inflames them and causes them to get misshaped and causes a lot of pain and aggravation, especially early in the morning. In the morning, you're going to see them with morning stiffness. There's hard for them to walk because they hurt their hip joints, their knee joints, their ankle joints. They could be limping. You might see some joint disfigurement. And the one thing that we don't all remember is the uveitis. They will get the inflammation in their eyes and they need to have ophthalmologist visits once a year to look at those eyes, making sure there's no danger. So, how do we diagnose JIA? Well, I wish we knew a better way. You know, I've told you all, I do have rheumatoid arthritis. I didn't know I had it till about 2008, and I didn't know how to treat it till about 2019. I mean, it took me a long, long time to find out that, yes, they gave me the diagnosis and then the treatment for it. And it's because there's really no definitive tests. Yes, we can do all the inflammatory tests, the sedimentation rate, the CRP. We can do the ANA test. We can do rheumatoid arthritis tests. There's one test now that they're doing called the CCCP. And that's the test that they finally said, yeah, you have rheumatoid arthritis. And I went, you know, I've been trying to tell you this, but nobody listens to me. And finally got on a type of treatment, which is, of course, methotrexate and biologics, which is what the treatment is for juvenile rheumatoid arthritis also. So what is our goal? Well, kids getting JIA early, we want to keep those joints as nice and free from deformities as we possibly can, okay? We want to keep them comfortable. These children need to be up, moving, exercising. You know, as I always say, what's the best exercise for JIA or even myself? Put them in a swimming pool because it's free It's not like you have to move against anything. And in a pool, most children enjoy it, that they can just bounce and jump up and down and they're exercising their joints. Corticosteroids are only for flares. They're not given consistently. On a consistent basis, be methotrexate and Humira. So they need their physical therapy, up moving, exercise, relief of pain. They need when they're in pain. Do they like heat or do they like cold? Do not give me heat because it will make me scream in pain. Give me an ice bag and soak me in an ice tub, and I will be happy. Again, every child is different too. Some of them like heat, some of them like cold. Some of them like heat some places and cold other places. Again, finding out the kid likes, okay? And again, giving them support because it's lifelong. There's no cure here. Now, lupus is just like JIA, but lupus attacks all of your organs, whether it's your skin, your brain, your heart, your kidney, your livers, it doesn't really matter. We do see it a lot in girls and young women, ages 10 to 19. And we think maybe it's that hormone change, that puberty sort of thing that goes on, or it could be due to these other things here. And the other one is overexposure to sunlight, believe it or not. So this is the butterfly rash child where you see it now. Doesn't have to look just like this butterfly rash. It could look like, just maybe a red splotch. This one's sort of splotchy all over. I mean, they're all different, but you'll see some sort of rash on the face, okay? Then you're going to see that pains, sort of the stiffness. Then it gets the nausea, vomiting, and then all of a sudden with lupus, it could go to the lungs, pleurisy, heart, pericarditis, goes to the brain, forgetfulness, and now seizures. And that's usually when we figure out what's going on with these children. Goals of treatment, these kids do get prednisone every day. They do get a low dose of it, and then maybe something else to help them. And again, every child gets a different sort of therapy. And again, it's compliance and minimizing sunlight. So, Kristen, 10 years of age, sustained a fracture in the epiphyseal plate of her right fibula when she fell out of a tree. When discussing this injury with her parents, the nurse should consider that what? What is an epiphyseal plate?
I would say B because the bone growth can be affected. The
Absolutely. The
growth plate.
epiphyseal plate is the growth plate. Excellent, Augustina. Thank you so much. Remember, epiphyseal plate fractures could have open reduction, internal fixation, because we worry about the arm, the leg being crooked, and then the growth. Very good. Okay, neuromuscular and muscular dysfunction. Let's go to cerebral palsy, CP. This is something that we do see in children, and the definition is basically a permanent disorder of the development of movements and postures causing activity and limitation. So we don't know all why, how it happens. We do know that most children with cerebral palsy will end up with epilepsy also. These are the things they think why it happens, whether it's some problem in the brain, low birth weight. I've seen a lot of children at birth have hypoxic, anoxic episodes who end up with all different types of CP, from mild to severe. It all depends on the length of time of anoxia or hypoxemia. So, how do we diagnose CP? Well, what do we do every visit? It's like we do all of these developmental testings. Would we see CP at first? No. Because remember, all babies don't move their heads, they don't lift their heads. All they do is suck, swallow, and breathe at birth, right? So if they need help with feeding, that might not be that abnormal. But as they get older, they're not going to be lifting their head by 3 months. And we're going to start saying, okay, we have problems here. Let's look for it. Now, there is a type of cerebral palsy. When we think of CP, I think this is the one that we most generally think of. Not the one who's mild, but the one that's more severe. This is like my good old Mr. Jonathan. I loved this little boy when I did clinicals, and he was this little boy in a wheelchair. CP, nonverbal, but he would see me. His arms would come up and he'd start shaking in spasms, and he would smile from here to here. It's hypertonicity, poor posture, and difficulty maintaining balance. He had to be in a harness in a wheelchair, but he got spastic when he would see me. And that's how I remember spastic cerebral palsy, because good old Jonathan. Now, what do you see with cerebral palsy? Remember, it's all different levels from mild to severe. Gross, fine, and gross motor development. We're going to see it delayed, okay? They are going to have alterations in their muscle tones. They're not going to be sitting right. Their posture is going to be different. Their reflexes are going to be different. And then they get other sort of disabilities with it, not just cognitively. They're not going to be able to walk. Maybe they have problems eating. Remember, it's whole different things that this could be here going on. So a milder cerebral palsy child still needs to be able to get up, get out, and move around. And I just love this picture. Here's a young child. He's got ankle bracelets on, so there's something happening with him. But he's smiling because he's up and he's able to move around and be mobile. Would you like to have to sit in a chair and not move all day long? You're not a kid if that's the way you are, even if you're cognitively delayed or not, right? So getting them up, getting them moving, getting them as physical as we possibly can, and teaching. Jonathan was nonverbal, but he did have an iPad. And on that, he was taught by speech things like colors and shapes and things that we never taught kids before in the past. I mean, we realize that these children do have the opportunity for learning, and we need to teach them as much as we can. And once they get that goal, they complete that learning, give them a new goal and teach them some more, because they have more possibilities than we ever thought, to tell you the truth. As I said, cerebral palsy, sometimes with their muscles in control, they might need those ankle foot bracelets. Sometimes we have to do surgery, sometimes Botox, because their muscles are such in spasm. I've seen all of these things used really well. And as I said, most of these children can have epilepsy. So that would mean they have seizures. So they would be on maybe that medicine, phenytoin, which causes gingival hyperplasia. So be careful. Dental hygiene. You have to be careful with that, with these children, making sure. Also, these children, if they can eat, making sure you give them extra time. Their muscles don't work right. Sit them up, tall. Give them the extra time to chew. Maybe support their chin if you need to, and let them eat and taking their time. So the prognosis of cerebral palsy depends on how severe they are, from mild to moderate, right? And it could be totally severe where they need total care. Remember, it's not just the child, we got a family in there. And always with cognitively delayed children, autistic, cognitively delayed, doesn't matter. Always be concerned, safety, 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 okay? Now, do you remember in pharmacology, they told you that you need to take folic acid 1 month before you become pregnant, or it could cause a neurotube deficit. Does anybody remember that saying? I taught pharms, and I still teach pharm occasionally, and I still remember it. And I'm like, does people really understand what a neurotube deficit is? I used to always tell my students, when you get to peds, I'll show you the picture. Well, this is a neurotube deficit. The neurotube is your spinal column, your meninges, and your spinal cord. And for some way, it's not going the way it should. When we talk in peds about it, we're mostly talking about the myelomeningocele type of thing, a big blob on the outside of the lower back. What's inside that big blob? It's the meninges, and it's the spinal column. And it's pulled up the nerves from the lower extremity to be able to bubble out like that. So you're going to have decreased feeling and sensation in the lower extremities, okay? It's sometimes a neurotube is that folic acid thing. Sometimes it's due to mom and diabetes, could be that. Know that when this baby is born, what is your care? What's your nursing care? Well, number one, this child has to be on their abdomen, never on their back. So this is the one time they can be prone. So they have to be on a monitor to monitor them. That big blob is part of their central nervous system. It's meninges, it's a spinal cord. We need to keep it sterile and protect that skin so we can close it. Also, from birth, these children are made latex allergy. There are many of them going to go many surgeries. A lot of times they're incontinent or they have urinary retention because they don't urinate, because they don't feel that down there because the nerves have been ripped because it was pulled up into that sac. So we don't want to over touch them with latex because they do and have in the past developed bad latex allergies, okay? So we're watching urine because the nerves are damaged. Also, we're watching their bowels. Are they moving their bowels? Because remember, nerve damage. They may not have the nerves to feel that they're full of urine or feel a stool. So it's to give folic acid, like I said. Now, spinal muscular atrophy, I'm going to give you two types. This type is the worst of all sort of spinal muscular atrophies. It's called Werdnig-Hoffmann. It's also called floppy infant. We usually see this right after 2 months, where they're not lifting their head, they're not rolling, they're just laying there. They're barely even trying to suck, swallow, and breathe. They're not crying. You can see that they're weak, okay? They usually die by age 2. There's nothing we can do. There's no cure here. Now, the one that is the most tested, I told you, tetralogy of Fallot, Duchenne muscular dystrophy. You're guaranteed, see them on your HESI, guaranteed, you're going to see them on your NCLEX, guaranteed. Duchenne muscular dystrophy is boys. Usually we make the diagnosis somewhere between ages 3 to 8. And it is what we call a pseudo-hypertrophic muscular dystrophy. You're going to see big calf muscles, big upper arms. They're just hypertrophic, big muscles there. It comes from mommy. It's X-linked. So we need to make sure we do genetic counseling on this mother to make sure, because it's all male births. So what happens with Duchenne muscular dystrophy? So this baby is normal, eating, drinking. We might see those calves bigger and whatnot. They might see slight cognitive delays, but nothing crazy. And then all of a sudden, what happens? They start falling down. They start waddling. They start crawling up their legs to get up. That's a Gower sign. I do it all the time. Get on the floor, crawl up your legs to get up, right? Their muscles are so weak. So they were walking and all of a sudden they're going backwards. We need to go check those muscles and check, how good they're working. And we do that with something called an electromyography or an EMG. Now, an EMG is a test where they put either those skin tabs or tiny little needles into nerves, and that tiny little machine delivers an electrical impulse. And it measures how quickly that muscle responds and how much strength that muscle had when it responded. So after they do this test, this child is going to feel like they went through a marathon because they're spasming all of these muscles that haven't been worked like this before. So be guaranteed this child's going to need some acetaminophen or ibuprofen when they get back to your unit, okay? So these children, moderate mental impairment, cognitively, they will be delayed. And then you're going to see those calves and you can see those arms and you're going to see them start falling over. You might even see lordosis on these children. So let's keep their muscles moving the best we can. So physical therapy, right? get them away for locomotion. That many of them end up in wheelchairs in the end. And again, genetic counseling because of the mother, because it will reoccur. It is an X related gene. And then Guillain-Barré. This is children are less often than adults. But you need to know what it is because Guillain-Barré is when all of a sudden it's called an acute demyelinating polyneuropathy. What does that mean? It means the nerves stop working and it starts from the feet and the nerves stop going up all the way to the phrenic nerve, which is your diaphragm, and it stops working in the diaphragm and you stop breathing. They say it's a viral thing. They say it's following some sort of upper respiratory again there. What we see with these children and adults, okay, is all of a sudden they start shuffling, they falling down because their legs are weak. Then they start being incontinent or can't urinate or start constipating where they've not been constipated. You know, these things start going on, and what they'll do is, you know, put these children in and check them. These children, minimum, have to be on an oxygen saturation monitor. And why? Our biggest concern is the nerve, the phrenic nerve, stops working, diaphragm don't work, and now this child's not breathing. Now, what happens? This child is awake, alert, oriented, but cannot move. Can you imagine? So, these children need a ventilator, which will breathe all of their breaths. And we will be giving them IVIG, which is your intravenous immunoglobulins. We might be giving steroids, but we're going to support them on a ventilator and giving them the nutrition that they need and whatever else they need to maintain. And then all of a sudden, you're going to see that child start breathing over the ventilator. So if the respiratory rate was set at 20, all of a sudden you look down and the respiratory rate is 24 and it's 26 and 28, and you start seeing it. And now you know that nerve damage is going away. Now it goes from phrenic nerve, goes down to the belly and down to the feet, and they start walking again. And again, depending on how long they were immobile, depends on the therapy. Now, tetanus is stepping on your dirty nail, right? It's also called lockjaw. And the reason why it's called lockjaw, tetanus affects the airway and it causes the muscles to get rigid and spasm and close that airway and you can't breathe. That's what happens. So these children come in and they go ICU and they will be given tetanus, toxoid vaccine, the tetanus IVIG, all of this to try to get rid of it, supporting this child on a ventilator, making sure. And because what it causes that big muscle spasms of the throat, place these children on really strong muscle relaxants. Usually, if we can get these kids over the first 4 days, they will recover. But this kid is a sick kid. So tetanus vaccines are very important. Step on a dirty nail. How do we do it? Well, we don't just treat it with the tetanus vaccines and all of those things. Remember, wherever they stepped on or got bit or whatever, wherever the tetanus came from, that we do clean that wound. Okay, very, very important. Soap and water and put an antibiotic ointment on it, right? And that's how you would treat it. So in the ICU, kid, paralyzed, sedated, because we have this muscles that are swollen up in the neck. This child can't breathe on their own because of this tetanus. We're going to be monitoring them completely. Fluid, electrolyte. We're going to be giving them the muscle relaxants, sedatives. We're going to have them on. It's Pavulon. It's the big, big, big muscle relaxants. When you go to surgery and they knock you out, they give you Pavulon. That's the sort of medicine it is. And they start to wait for you to see, again, how are you breathing? Now, botulism, similar. Has any of your grandmas or aunts told you, oh, your baby's constipated, give it a little bit of honey or a little bit of Caro syrup? I mean, it does happen. Don't do it. And the reason is there's botulism in honey or Caro syrup. You don't know how long has it been on your shelf? How long was it on the supermarket shelf? Is there any sort of sterilization with it? Who knows? So they say no honey, nothing till you're age 1, period. That's what they say. What happens? Well, basically the same sort of thing. It goes into progressive respiratory paralysis. It starts again with trouble with speaking and speech and all that sort of stuff. Again, putting them on respiratory support. The kid's, has this paralysis going on and will be given the IV botulism immunoglobulin, of course, keep them paralyzed, sedated, and this eventually they will wake up and do better. Now, spinal cord injuries. Let me tell you about my little 16-year-old boy. I was the primary trauma nurse on a Saturday, of course. And the 16-year-old boy was out playing baseball. And he slid into third base and his head hit the defender in the knee and Stan's heard a crack. The child went flat on his back. The right leg was numb and the left leg was feeling tingly numb. They called in rescue, put him on a helicopter, and coptered him into my hospital where I took over. This child had a right numb leg and the left leg, he could barely feel his toes. Only 2 of his toes he could feel. I'm the nurse in charge. So, what is my responsibility? You've already got a kid who has a spinal cord injury. You better make sure you keep that neck immobilized and they don't move or twist the neck. This kid is this close from being paralyzed, and we don't want to do this to this 16-year-old kid. I had to take that kid to the MRI that day. Only MRI I've ever done in an emergency room. It's usually not an emergency thing, but this kid it was. He had an angulated C5, C6 fracture with all of this deficit. So what did we do? We brought this child up to the PD ICU, put tongs in him, put him on a cooling blanket for preventing swelling. And the following day, they did his surgery. Okay? Actually, it was a Sunday night when this happened. That's right. Next day, he went to surgery. They plated him, did what they had to do. 2 weeks later, I said, let me go check on this kid, see how he's doing. I had a moment in the ER to do it. Unusual, but I did have a couple minutes. So I went up. This child's right leg had a little bit of tingling in it, but the left leg was fine. He was being discharged the next day, and he was going into rehab just to get his strength back. A year later, that boy walked into the ER, walked right up to me and hugged me and goes, look, I'm doing great. I have no deficits and I'm playing baseball again. And it just makes all of that stress, all of that time, making sure I'm in charge, move on my count. And again, immobilization was my priority. And that's what I want you to remember. I prioritized that neck was mine and nobody was touching it. And that kid had a great outcome. So, what is that progressive infantile spinal muscular dystrophy that's called floppy infant? It's the wording, Hoffman. I won't make you guys suffer. So a lot of stuff, a lot of different things here. Anybody want to win a cahoots today? Liz May, you want to win?
I'll try my best.
How about you, Lindsay? You ready? I know you are. You're going to do it. Zarina, want to come on camera for me? Please. I want you to know that they do go back and check these recordings at times, and I'm just making sure that you guys are all safe by me telling you to get back on camera. I know sometimes you got to do things. I get it, but I'm just protecting you. All right, let's get going. My head is hot. Night night. Okay. Week 9. What is a priority for a nurse to assess following a cast application? So when we're talking about anything with cast, remember your 6 Ps. That's what this question's about. Pulses, pain, movement, sensation, paresthesia, right? Paralysis. This is what we're looking for. A multi. Patient teaching for a child with a fractured bone that has had a new cast applied. So whenever you have a new cast applied, remember nothing inside it. Cool hair dryer is great. No powder, no lotion. It's just going to make a big cloggy mess in there. And of course, any hangers, no. And swimming, absolutely not. They say they want their cast dry. What should the nurse monitor after a soft tissue injury? A bruise, a crush, an ecchymotic area. What do you need to be looking at? So anytime, any injury, always do neurovascular signs. Do a neurovascular check. Are the toes pink? Have we got good capillary refill? Are the fingers pink? Good capillary refill. Very important to get to that, to remember it. Get in the habit. A fracture that penetrates the skin is called what? So open or compound. What's the treatment for an open compound fracture? Well, antibiotics, right? Our biggest concern is infection. A multi. A Bryant's traction. What's that? What is it for? So used for children less than 30 pounds. It's for that hip dysplasia. Yes. The hips are elevated up off the bed on a right angle. And yes, you always, with any traction, you're going to check for breakdown. Very good. What is the priority nursing care of a child with a compound fracture? What's a compound fracture? Compound, open fracture. And again, IV antibiotics, #1 priority. Okay, priority nursing care is always going to be your antibiotics. Yes, we're going to check neurovascular signs as a part of it. Sure, but the IV antibiotics are going to prevent osteomyelitis. What is priority nursing care for a child who fell off a second floor balcony? Believe it or not, in my career, I've seen 3 kids fall off a second story. They get up on the chair and they get on the top of the railing and they have fallen off. And I've seen 3 different outcomes. So remember, you have fallen. What is our biggest concern? Our biggest concern is going to be the spine. Is there any sort of injury, right? And then after that, we'll do the rest of the stuff. But first of all, immobilize the spine and then do your neuro checks. Principles of managing soft tissue injury include sprain, a strain. What are you going to do? It's going to be that RICE thing. Rest, ice, compress, and elevate. Absolutely. So there's 2 things you need to remember about orthopedics. RICE, rest, ice, compress, elevate, and your 6 Ps. Those 2 things you need to remember. Epiphyseal plate fractures in children may what? What is an epiphyseal plate? Again, epiphyseal plate, growth plate. Again, we're worried about the disruption or getting an irregular shaped bone. So again, it disrupts the growth. Very good. What findings for a patient in skeletal traction indicates peripheral neurovascular impairment? What do all those words mean? So neurovascular impairment means there's no pulse or there's a decreased pulse. There's no capillary refill, prolonged capillary refill, any of those things. Peripheral neurovascular impairment. A multi. Who should the nurse care for skeletal traction for a child with a fractured femur? Many times you're going to see bucks traction and it's going to be on the elderly that has a fractured hip. They also use that bucks traction on those patients also. And the same treatment. Make sure you document the weight and make sure they're hanging freely, right? And what else you're going to do? Document neurovascular signs. You never reduce the weights. You never remove the weights. If you can imagine a fractured femur, you take the weight off, those bones are going to dislodge. You're going to cause muscle spasms and pain. Never, ever remove the weight. When caring for a 9-year-old in bucks traction, what action by the nurse is correct? So, bucks traction, what's correct? Always check capillary refill. You're never wrong with that. Very good. You don't want the head, usually with these children and these beds, we turn the bed off. They can't go up and down. I mean, head of the bed up and down, but even the foot, we turn them off so they can't mess with it. And again, never take off the weights. And if you're going to sit on the bed, you're going to hurt the child. Then it jostle that femur, it's going to hurt. What position do you put the legs of an infant with hip dysplasia? It is called abduction, okay? That's one of those positions. It just brings it in so that these hips can fall right back into the hip joint. What statement by parents indicate more teaching is needed regarding their 2-month-old with club foot? Now look at the club feet on that baby, the picture I gave you. It's quite intense. So remember, club feet, they're congenital, they're born with it, their bones heal really quickly. So every week they need to come in, not every month, okay? So remember, they heal very, very quickly as a neonate. So that would be the one. Treatment needs to be started quick because they heal quick as a young neonate. Number two, they're going to need follow up with orthopedics or with podiatry, making sure their feet are still good. They might need special shoes. And then every week is way too long to wait. Every month is too long to wait. Every week they got to be there. Die. Osteogenesis imperfecta. OI. So OI is congenital. It's something that's given to the baby. It's called brittle bones. We don't know why. It happens. And then everything becomes crooked. And these children you have to treat with kit hands. As I said, I didn't even like to touch them. I would use the blanket to move them around from here to there. So no aggressive physical therapy on these children. Our goal is to try to keep these children in an alignment where they can be up and still mobile, like sit in a chair or sit in a wheelchair, okay? What is the pathologic cause of late calf burst disease? So late calf birth is that femoral head, and that femoral head has an ischemic, which means blood's not going there and it's dying, and we really don't know why. Again, treatment's conservative. We're going to give NSAIDs, bed rest, maybe put some Bucks traction on it, and hopefully we can save that femoral head through NSAIDs and bed rest. Kyphosis. Kyphosis is the humpback. It's the upper back. Study. What assessment indicates an infant has developmental dysplasia of the hip? So when you see a child that the hip is not in the socket, it's up here. So that leg on that side is going to be shorter. Okay, that's one of them. The folds, the gluteal folds, one will be crooked, one will be up and more than the other. You're going to have positive this moral reflex is a startle reflex. That's an infant. That's not what developmental hip dysplasia is. But he has Babinski reflex from children all the way to adults. And then, of course, you have the positive Ortolani sign and the clicks that you can hear. Lordosis is described as so lordosis is the lumbar spine. It goes in. It's sort of like you walk sort of, sitting back, like sitting back and moving, usually with big pendulous abdomens too. Scoliosis is Scoliosis is an S-shaped curvature of the spine that usually happens at that pre-adolescent growth spurt. And that's where we're able to see it more, where that one shoulder is lower, and you'll see it curve. And it needs to be fixed in either through physical therapy and a brace or through a surgical procedure. An adolescent with scoliosis that have up to a 45% curvature of spine would need to do what? What's the treatment of up to 45%? For up to 45%, wear the brace 23 hours a day, to take a shower, make sure there's a good cotton t-shirt underneath. And these children, with the exercise, strengthen their muscles, and they're not going to need surgery at all. After that, they will need surgery, usually a Harrington rod. A multi. Teaching for a child with scoliosis with less than 40 degrees of curvature. So again, with scoliosis, you need to know what you can just do physical therapy and a brace for, and when do you need to go to that extreme of surgery. And again, over 45 is the surgery. Underneath is wearing a brace and just taking care of it. No lotion, exercise, cotton t-shirt, 23 hours a day. Multi. Pavlik harness. So if a Pavlik harness doesn't work, we can do Bryant traction, right? Or we can do a spica cast. Or we're going to have to do surgery and to release it and remove it. Again, Pavlik harness is for those hip dysplasia. It holds for abduction. Always check underneath the skin, and then you massage it when it's off. So remember, get them off for a bath, massage them, change them, new t-shirt, and making sure that it's working without causing any other injuries. What is osteomyelitis? So osteomyelitis is osteo is bone, itis is inflammation or infection. Inflammation condition of the bone caused by infection. Very good. Goals for juvenile idiopathic arthritis includes so JIA is all about the body attacking the joints, and it hurts. They're swollen. So our goal is to reduce the pain and the swelling, to try to keep those hands, the fingers, whatever, keep them from keeping them functional, basically. A multi. What might you anticipate for a child diagnosed with JIA? So facial rash is lupus, okay? So joint, yes, difficulty walking because the joints, the hip joints are stiff. And remember those eyes, the uveitis, and get them to an ophthalmologist once a year. What is cerebral palsy? Cerebral palsy is when you have no control in your muscles, the body movement, and the coordination. A multi. What are the signs and symptoms of spastic cerebral palsy? So, poor posture, hypertonicity, poor fine motor skills, poor balance, poor everything. They're going to be really delayed, and they're going to see that spasticity on them. Multi. When feeding a child with cerebral palsy, what's important to remember? Remember, cerebral palsy is all about muscle coordination and movement. What would you be concerned about if you had to feed a child with cerebral palsy? Absolutely keep the head of the bed elevated. Give them that time. Excellent. Very good. And we don't use thin liquids on a child that has trouble swallowing. We actually thicken those liquids. You know, one of the things is you think all cerebral palsy children need a gastrostomy tube. Remember, there's mild to severe, and not all of them need a gastrostomy tube, or some use both. A myelomeningocele. What did I tell you happens? That's that blob on the back, right? So it's ripped up, the meninges and the spinal column. What are we concerned about? It's a big hernia of the spinal cord and the meninges. It's ripped those nerves coming from the lower extremity, and that's our big concern with myelomeningocele. A multi. What can help a child with lupus erythematosus prevent exasperations? What I tell you, one of the biggest things is with lupus. You know, lupus is an autoimmune. So one of the things with lupus is to be careful with sun and to wear sunscreen, of course. And then, of course, it's that prophylactic antibiotics before things like dental extractions. They're immunosuppressed. Infants with myelomeningocele demonstrate what? Remember, their spinal cord and nerves have ripped up and come to the outside of the body. And it's going to be motor and sensory impairments. You've got to monitor urine and stool on these children. Myelomeningocele have decreased motor and sensations of the lower extremities. The nurse should monitor closely what? So big thing is urinary retention. Many myelomeningocele are so they don't have any feeling down there. They don't move at all, and they're on Q4, Q6 hour, catheterizations. In fact, many of my nursing students get to do urinary catheterizations because of some of these children that I have taken care of. They get to the point as adolescents they do their own catheterizations. A key feature of Duchenne muscular dystrophy is what? Muscular dystrophy. What is muscular dystrophy? It's muscles muscles stop working, and the name is Duchenne. It's progressive muscle wastage. And the muscles that we're concerned about is the muscles for the diaphragm, so breathing, and the muscles of the heart, which is your heart beating. And when they stop, usually about teenagers, is when they usually pass away. One of the procedures that a child with possible Duchenne's may need to diagnose the condition is called what? And you can see this one has little tabs, and he also is using a little needle, like an acupuncture needle. And they use all different things to monitor it and look at this stuff. And it's called an EMG. Remember, post this procedure, these children look like they've ran a marathon. Make sure you give them something like some Tylenol or some Motrin or something. How is Duchenne muscular dystrophy inherited? So Duchenne's comes from an X-linked pattern, comes from mommy. That's why genetic testing is needed. In caring for a patient with Guillain-Barré, the priority concern is what? Remember, the nerves stop working from the feet working up. It's all of a sudden they just stop for whatever reason. So our biggest concern is the phrenic nerve in our airway so that we can breathe. So again, Guillain-Barré patient, what are you going to expect? Guaranteed minimum. They're going to be on a saturation monitor, and they're going to be in some sort of monitored area if they're suspecting this, because these children and adults will stop breathing and require intubation and a ventilator. For a patient suffering with Guillain-Barré, they would complain of weakness that was what? So it's basically what we call ascending, which means it starts from the feet and it ascends upwards until it gets that phrenic nerve, okay? Ascending. Multi. Treatment for Guillain-Barré include what causes Guillain-Barré? So it's not a bacteria that causes Guillain-Barré. They think it's some sort of viral from an upper respiratory, but I'm not sure. Something with the immune system that happens. So we give IVIG to help the body give itself some more immune support. And because their phrenic nerve stops working, they're going to be on respiratory support until they start breathing again by themselves. Now, treatment for Guillain-Barré, is it heparin? We might be on to prevent blood clots, but it's not treatment for exactly Guillain-Barré. What type of cerebral palsy causes hypertonicity and poor fine motor skills? What is it called? And it's called spastic cerebral palsy. What priority action should a nurse take to a patient with a suspected spinal cord injury? What is your priority? My little boy coming in with a C6 fracture. What was my absolute priority here? I'm going to take care of that spine. And today I know I have a kid who's running around. I hope he's married and has 3 kids and is happier than ever because I made sure that I didn't let this child get paralyzed. What should a tetanus shot? When should you get a tetanus shot? How many years? You know, during my career, this has changed so many times. What is the latest? And it's 10 years now. Do you know it used to be every 2 years? Then it was every 5 years. Now it's every 10. And they're also given diphtheria with tetanus now. What is a symptom of tetanus? And it's called lockjaw. Remember, everything squishes up. We've got to get them on ventilatory support, and we're going to be giving tetanus toxoid and cleaning the wound. Last question. Most common cause of spinal cord injuries are? And it's motor vehicles, driving, and or sports. Yes. Number 3 is dead inside. Yay. Brenton. Good job, Brenton. Number 1. Nina. Good job, Nina. And SS and Alala. I love the names. Anyway, we're done for tonight. Remember, you do have that calculate with confidence discussion question. Anybody who wants to get with me before exam 3, please make that appointment. I'll be glad to meet with you. I do my review tomorrow at 2 o'clock if you want to join me. Yes, it'll be posted shortly thereafter, so you'll have the recording if you need it. Everybody, you have a great evening.
Good
Thank you.
night.
Good night, guys.